We're very passionate about what we do with instructing. We do it because it's something we feel that needs to be dealt with in a level that people can respond to it and actually help and save another human being, be it BLS or be it what I do on an ambulance all day long. But our passion is really just being able to help other people get to a better level of care.
That's when you shake out those like, oh, I didn't do this, or, I forgot to do that. Work that all out, because when the emergency is happening and you can act flawlessly, it directly affects patient outcome. That's what the important thing is, because minutes do matter.
Even we talk about bystander CPR, and you did take a class, and we talk about the relevance of a quick response, and that's really what our key is to have somebody initiate quickly if it's in a bed, if it's on a stretcher, is to get those compressions started and get those compressions non-interrupted.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 254. My name is Andrew.
And this is Michelle. Welcome to the podcast. If you're a new listener, welcome. We're glad you're here.
Yes, welcome indeed. We have started if you are a subscriber, you have already heard this podcast. But we have on Mondays a new short segment called Fast Facts Perio Edition. If you are not a subscriber, I recommend you hitting the subscribe button so that'll be delivered right to your app every single time. It's really good. It's really good. We have Katrina Sanders giving us a 2 to 3 minute quick soundbite on something that we all need to be doing better on, and that is perio treatment and diagnosis and assessment and all of the different things.
Yeah, there's a lot to keep up with. So if you haven't taken a perio course in a hot minute, this might be a really easy way to stay in the know. I love all of our content.
Yeah, I do too. I think the thing I like about hers in particular is it is dense, right? It is a dense 2 minutes. But I was listening to it the other day, and I've listened to all of ours for a couple of times now each. And every time I heard it, I heard something new in only 3 minutes. Her episode's only 3 minutes long. I'm like, oh, I missed that in the first time. We also have a transcription service that does it, and that's going to be on the Coast Dental website, but you can read through it, and I learned something new when I did that as well, and that is interesting. So anyways, just a little something for you guys to do.
No, I think that's a great point. And I've listened to some heavy podcasts, not just ours, but other ones. I listen multiple times for it to really sink in. And, we've had some guests come on or I've had people that have thought about being guests and just kind of shied away from it because they didn't want to give their content out, right? Like they were worried that people, if they hear it on the podcast, they wouldn't come and hear them in person, all that. And I was like, who watches a good movie once?
Yeah, right.
You go to see a movie in the theaters, and then when it comes out, you're like, oh my gosh, I didn't even remember that scene. I didn't remember that moment. I didn't remember that great quote. I didn't remember that emotional, whatever. I was like, if it's content that really matters, people are going to hear it, and they're going to hear it a lot. I think Stasha Gomanek. And
then they're going to tell their friends too, right?
Exactly.
Yeah.
Stasha Gomanek is one of my favorite ones. I've been to her course twice. I interviewed her twice, and I have still listened to those episodes multiple times because there's always something I grab from it. And I think it's such an important topic that I continue to listen. Same with myofunctional stuff, same with all of it. Listen to it a bunch of times. Why not?
For sure.
I did want to bring up one of our old podcasts, not old, it's only a few months old, but we talked about fascia on one of our podcasts. We'll link it in our show notes because now I can't remember the episode. There's just too many now. I just have too many.
They'll run together.
But now that I've been seeing patients again, my body hates me, even if it's just one day a week. I always think, I'm like, how did I do this 40 hours a week? Like, oh my God. But we already established a lot of it was my emotional connection to the patient, not feeling like I could help them. But anywho, I have started getting Thai massages, and my massage therapist is also somebody that focuses on fascia and has been using my fascia blasters. Like I used to talk about a billion times on the podcast, probably like 3 years ago.
I remember.
I love those fascia blasters. She's been using them, and especially on my forearms, and tight forearms create a lot of shoulder pain. Wink, wink. I know you guys are suffering from that, and into the neck and all that stuff. And so it's not always I just saw somebody talk about like, do I go to a chiropractor? Do I go to massage therapist? And I've been to PT, massage. I've had dry needling. I've had chiro. I mean, if you can name it, I've probably gone and given it a try. And I'll tell you, it all comes back down to our fascia, because our fascia is going to protect our muscles. So you could get massages, you could do things all day long, but if you're not taking care of your fascia, it's not going to last you. In addition to strength training and doing these very simple strength training exercises to keep your body right, y'all. Not just because you want to be tight and fit, but because you want to work for a long time without pain.
So for those of you that are out there listening to this and you're like, okay, I've heard Michelle say this multiple times. She's just on one of Michelle's kicks, like as she does. But let me tell you this. Let me help convince you from a different angle. Tom Brady was on a podcast recently with Dak Shepard.
Dak Shepard. I just listened to it this morning.
Similar type stuff. Kind of is at the very, very end of it. He talked about inflammation and, eating right, and how like, inflammation on inflammation and this and that, and, elongation and stretching and all of these things. So if you don't want to believe Michelle, believe the winner that is Tom Brady.
The best quarterback that ever lived.
If we can cut that part out, that Michelle said that,
and
use it every other episode, that would be fantastic.
Take it with a grain of salt, because I watch football all of never, and I actually forget NFL even exists.
Doesn't matter. You said it. It's out there now. It's truth. So thank you for acknowledging that.
I mean, he's the oldest quarterback, correct, in the NFL right now?
Yeah.
Yeah. I mean, that says something and he's won multiple. What are they called? Super Bowls and stuff?
Yeah, what has he won? Use all the terminology. Yeah, I mean,
he's won those games and stuff. Those things that people
championships
freak out about in February on Sunday. Yeah,
you got the right too. That's pretty good. That's good.
It's always because I will say, as much as I could care less, or is that right? I always say that. I couldn't care less.
You could not care any less than you currently do.
I could not care any less. Thank you. I could not care any less about Super Bowl. However, I do think voting day, the day after voting, and Super Bowl, the Monday after Super Bowl should be holidays.
Look, I'll support that 1,000%. Or as Bert Kreischer says, 100%.
100. Yeah. So I'm a big fan. But I didn't finish that podcast with Tom Brady all the way. I'm like halfway through. So I can't wait to get to that point where he solidifies my point right now that I have just made.
Yeah. I mean, it's going to be like it's going to just barely kiss and then not be as interwoven as I was hoping. But he's got a whole line of health stuff that you guys can probably like figure out and listen to. I feel like my
go back
voice
and listen to Uchi.
Why is my voice all scratchy? It's ridiculous. Sorry.
You've been hollering, rooting.
I've been
for your
yelling at
team?
my stupid kids. That's not true.
Which is like, no, I was going to say.
I don't yell at my kids. I love them.
Your children are so wonderful.
Yeah. I don't know. COVID. It's probably COVID. It's fine.
It's the allergies.
Yeah. You know what's really tough actually is it's been getting, because I'm in Tampa now. It's been getting down to like 50 degrees in the morning and back up to the 80s in the afternoon. I'm like, this is just delightful. Sunshiny and just
living the dream in Tampa there.
Just living the dream in Tampa.
With Tom Brady.
With Tom Brady. I know I was going to connect all this. Tom Brady's down here also. But also, you know who could use a good Thai massage is Raphael Rondon. My little partner in crime over there at Coast Dental. That guy, his neck, he's always doing this thing. And like, he's not even clinical.
He needs that fascia blaster. I'll bring it down.
Yes.
I'll blast that neck.
For serious, would you? Because that'd be really awesome.
No, I would love it. Are you kidding? It's all I can do not to fascia blast people. I see them walking, I see things, and I'm always like, oh, I think I could fix that. I think I could fix that. Is it right to tell a stranger that they should investigate the fascia?
That's good. I love it.
You know how we're always like, we see a bad crown, you're like,
Yeah.
Or they got like just a little inflammation, maybe some pretty decent calculus you can see. And I'm always like, do I say it or not? Often I don't until I start drinking, and then it's all out the door. But anywho, this episode, because we're going to get on into that interview, is about medical emergencies. And last year, I'm going to try to revisit this each year. I think that's a very good thing to stay up to date on. And last year, I brought my BFF, Susanna Trammell, who was a paramedic at the time and a flight medic because she's a badass. But now she's an ER nurse. So she's in the ER. You know, her and my other friend just living those COVID nightmares. But she did that emergency, which kind of gave us our medical emergency podcast, where she gave us the perspective of like, if EMS comes, like these are the things that we're going to look for. This is what's going to happen. So I always appreciated that episode. But now we have Bruce and Patty on, and they are actually, Susanna was too, but a CPR instructor. They are the ones that give me my CPR updates every 2 years, which I think should be even more than that. But anywho, it's every 2 years required. And they did a fantastic job. This is the second time I've renewed with them. They're such great instructors. Patty is in dentistry. She was a dental assistant in oral surgery, has had to experience her own medical emergencies where she's done CPR on her dentist. So like it's super important, and it's fascinating. Just a little side note. I have a friend that's in hygiene school, and she asked like how often, I think I say this on the podcast. No, I can't remember, but she asked how often I've had to deal with medical emergencies, because she's like, do we really have to go into this kind of depth? And I was like, well, don't ask me. I think I was cursed very early on with way too many medical emergencies, because I've had a stroke. I've had somebody have a seizure. We've trached somebody in the chair. We had somebody that wouldn't clot during surgery. I've sent probably a half dozen people in an ambulance in my first few years of being a dental hygienist. So I learned very quickly.
And then like, you know, the thousands of patients I was seeing on those crazy hours when I was working clinical, and zero.
I know.
Isn't that weird?
It is. I mean, but honestly, I feel like a better clinician for it, because my health history questionnaires and questions and things I go through with my patients now, they're always like, God, girl, like, why you need to know all this stuff? I'm like, don't you worry. I've sent people home in ambulances, and these are the things that we need to know. I'm cursed, and I'm sorry. You might be the next. No, I don't say that to my patients, but that's kind of what I'm thinking. Anywho, enjoy this episode with Patty and Bruce from Holy City Heart Savers.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
All right, listeners. So, you know, last year I brought one of my BFFs on who was a paramedic, and we talked medical emergencies, and I found another amazing clinician a couple clinicians, providers of care that are going to kind of give us some reminders, maybe even teach us some things about medical emergencies, especially in the dental setting. So Bruce and Patty, welcome to the podcast.
Hi.
Hey, Michelle, nice to meet you.
So tell us a little bit about yourselves. I mean, and I'll just go ahead and put it out there. I just took a CPR class with for your company, but Patty, I just had a wonderful CPR recertification with you.
Yeah, well, my name is Patty Emery. I have been an oral surgery assistant for 27 years. And my husband and I started this company 6 years ago, teaching CPR and first aid. We also teach bloodborne pathogens to the dental community. Since COVID stopped teaching infection control, I'm no longer in the dental setting, so I figured it would probably be best to take a step back from that. But I love the skill, and I love that what we teach. I feel like it's important to do it in a relaxed atmosphere to really give people the skills that they need to save some lives.
Hey, Michelle, I'm Bruce, Patty's husband. I am a EMT, first responder, and also a BLS, American Heart instructor. We're very passionate about what we do with instructing. We do it because it's something we feel that needs to be dealt with in a level that people can respond to it and actually help and save another human being, be it BLS or be it what I do on an ambulance all day long. But our passion is really just being able to help other people get to a better level of care. So we're really looking forward to your podcast this morning.
No, we all need this. And what's very interesting is that I have a friend who is in school right now, in dental hygiene school. And she actually asked me because she was taking her medical emergency course. And she's like, how often have you had medical emergencies? And I personally feel like I was cursed in my first 3 years of being a dental hygienist. Somebody have a stroke in my chair. I had somebody have a grand mal seizure. I've had syncope. We have nicked a lingual artery and had the oral surgeon there, and we had to trach the person. And we've had somebody with some kind of clotting factor issue. Oh, and then somebody with oral sedation, passed out in the bathroom up against the door, and we all were trying to push. I swear I've had more issues in my first few years. I'm glad it's all kind of stalled out and I haven't had to do any kind of crazy things in the last few years. But I've always worked in sedation practices. So I feel like we were always kind of up on it. And so now when I'm going into these other practices and I'm like, where is your AED? I'm actually a little surprised by how many people just, do those 2 years. Every 2 years, they get their certification for a CPR because they need their license renewal. And that's kind of where it ends. Do you see that as a very common thing out there in the dental field?
Yes, some really interesting facts for you. 70% of Americans don't know CPR. 70%. And here's another one that's going to shock you. 50% of healthcare providers cannot locate an AED or a first aid kit in their office.
Because they just don't know where it's at or what it looks like even.
They don't know where it's at.
Probably
they don't
both.
know what it looks like. And there's a lack of training in the practices. I know a lot of people feel, kind of like, I got to do this every 2 years, or again, we got to do this again. But the thing with practice and doing these mock exercises is so important, because when it's going down, that is not the time to learn where your materials are, how to use them, how they work, and things like that, because time is so important when these emergencies are happening. And when you do these mock scenarios with the people in your practice, that's the time that it's okay to mess up. That's when you shake out those I didn't do this, or, I forgot to do that. Work that all out, because when the emergency is happening and you can act flawlessly, it directly affects patient outcome. That's what the important thing is, because minutes do matter.
And outcome is pretty serious in this regard because they could die.
Absolutely.
I don't mean to giggle with that, but that is...
Nobody's got time for that.
That's the scary, unfortunate reality is that if we don't respond properly, we don't know what to do, what's next, then ultimately our patients could die in our chair, and that's horrible.
It could be a career changer for sure.
For sure.
I think that identifying a medical emergency, not all emergencies can be prevented, but just being aware and recognizing, I think that one of the most important things that assistants and hygienists can do in the office is go ahead and review that medical history. And I know that patients, kind of are resistant about filling out that paperwork again, and they'll tell you, oh, it's the same. Just verbally, hey, any new conditions, any new medicines, any new allergies? Have you been in the hospital recently? Because they might forget about, oh yeah, I had that foot surgery or something, thinking that doesn't pertain to oral health. And these things can. New medications, including supplements, we need to know about them. Another thing that I think is really important is at the beginning of the patient's visit, take those vital signs while you're talking to them about their medical history before you even talk about what they're there for, just so you can get a baseline, because their vitals might spike up when you start talking about what's going to happen during their visit. So you don't want to confuse that with what a resting kind of baseline vital signs are, with that patient. Knowing your equipment, knowing where it is, super key stuff. And it's easy to do. And it's just a matter of practicing. Take 20 minutes, maybe every year, every 6 months, and just let everybody know where the stuff is. And once it's there, don't move it. Like your AED, don't relocate that doing some housekeeping because people are going to look for it where its home is.
Yeah. And I'm a big proponent because I also have an infection control company, and I'm always about the standard operating procedures and like, how can you create documents? And I'm also big on videos so that you can share with new hires, with temps, with, I've always worked in pretty transient clinics where we have residents and students and all kinds of stuff coming through. And I'm like, let's take a video of where they can find that AED, where they can locate the emergency kit, first aid kit, whatever. So that, because for me, I'm always like, I don't know, in the moment, kind of stressed out. I'm going to go like, okay, where did I see it? Oh, it was in the closet. If I've seen it before.
Absolutely. Offices need to be familiar with where their stuff is, and doctors need to be involved with it too. I know that their time is valuable and all that, but when it comes down to it, I think I shared with you when you were in my class, the last person I had to do CPR on was actually my boss. And there was not anybody there for me to say, hey, what am I supposed to do next? So.
Because he was the person.
He was the guy I needed to help. So.
Oh, stressful.
Yeah. So you don't want to have to think about it, and just being prepared and being ready. If you practice it and you know where it is, you don't have to think about it. You can just move.
So one of the things I know that we're going to chat about is the importance of the medical history. I mean, you already brought up the idea that you need to ask them very specific questions. Otherwise, they will forget some things. And, especially if it happened just like a week after your last appointment, that was still 6 months ago. And
right.
Sometimes I don't even remember 6 days ago. So the big things that we need to ask them. And, Bruce being on the ambulance, one of the times that I guess the trigger for me to always be very on top of my medical history was because I was super embarrassed, because during one of those medical emergencies, the EMT and the paramedic was like, well, what's their current medications? And I was like, oh, it just says with our normal limits, no changes. And I just like, it was like a 2-year-old document. I just, and not just me, but that was how I was trained in this office as a year, was just like, and this was before, digital, we were still paper charts, but it was just like, 10, 25, 19, whatever, this no changes. And that was it. And I was so embarrassed. I mean, how often are you seeing that, Bruce, if you ever have to go into these offices?
A lot of my patients, when I get them on the ambulance and I start asking them questions about their medical history, a lot of the things they either forget, don't remember, or don't think it's important to document to me to tell me. But what happens, I'm an interfacility transporter, so I'll have medical records with me. So I'm reading their medical history as they're telling me their history. And it's surprising how many things they seem to forget to tell me about. A medication, a past surgery, or something they to them think it's irrelevant, but on a medical emergency, it could be something that could be very severe and problematic that could happen very quickly. So I'll take their word for where they're at, but also look at their medical history and then do my evaluation, because every person we transport is evaluated currently as they present to us, and then also their medical past history. So there's a lot of ongoing. It's very dynamic. It's not just what they say or feel. It's a whole host of a lot of attributes that come together very quickly. So we're responding rapidly.
So let's talk more about that medical history. Any thoughts on like specific questions that we need to ask them?
I would recommend that any assistant or hygienist, after you take those vital signs, if they need to pre-medicate, Have they had any joint replacement? Have they had any cardiac history? Medications that they're on, because they can cause syncope, passing out of somebody to faint. Also, diabetics, when was the last time that you took your medicine? When was the last time that you ate something? I've had diabetics come in and they haven't eaten since yesterday at noon. Well, you start to do a procedure and they start to get all sweaty and now it looks like they're going to pass out, kind of have an idea what I think is going on. So, those are pretty basic. An asthma patient, ask them to bring their inhaler with them to their visit, just in case, kind of thing. Those are pretty much basic ones. Diabetics, heart patients, joint replacement patients, asthma patients are ones that we typically see in the office that have a higher chance of a medical.
And no allergies. Yeah. That's very important.
Yeah. So if you take blood pressure, where do you start getting super concerned?
I start getting super concerned if it's super low or if it's really high. If it's really high, it's going to be 180 over 100. Now we're calling 911. Okay. The patient's still going to be with you. They're still going to be talking to you and they're going to say, no, I'm going to call my doctor tomorrow. And you're going to say, yeah, no, you're going to take a ride over to the hospital. Let them just check you out. You can't be wrong in doing that. I mean, now if you call 911 and Bruce comes and he takes your blood pressure and now it's back in a good range. Okay. I don't feel like anything is wasted by that. I'd rather check it out than be dealing with a full-blown medical emergency. Just check out those avenues.
Usually at that point, if that happens and we are called out, we have someone with the blood pressure like 90 over 50, and it does rise a little bit, we are still going to transport. We're going to have the patient evaluated further, because at that point in time, it's something that's,
it's not normal.
If it's that low, it's not normal. Now, granted, normal is a word we use often, but normal to a dialysis patient is not what we would find normal. Normal dialysis patients, they do run very low, but again, that's where the history falls into the fact is I transport a lot of dialysis patients and I knew their working history going into dialysis, coming out of dialysis, and they're obviously 10, 20 points lower, but a normal and a history is something that we need to have established and work that going forward.
So a key point would be to take those vital signs when they first come into your office, because if they present with something that is within normal range 120 over 80, okay? If they're somewhere close to that, then we're okay. If all of a sudden it spikes up, it could be from anxiety. We all know patients have anxiety in the dental office. So if you stop what you're doing and see if you can calm them down and it comes back down normal, yeah, it's anxiety. Okay, you can continue on. If you can't get that to resolve within 15 minutes, you need to just reschedule and send them to their doctor, for sure.
And then how long between the moment that you take it and you're like, okay, that's a little outside of the range I feel comfortable with. Let's give you 5 minutes, 10 minutes?
I would give 5-10 minutes, lay the person back, kind of supine or semi-reclined, and just maybe shut the lights off and just kind of start a note behind them and just let them kind of relax and see if they come down, then you're probably okay to proceed. But if it's not resolved, then it's, I would definitely have a doctor come in just to kind of back you up and say, yeah, this is a little elevated. We need to reschedule. And I recommend you go see your doctor. Unless it's like 180 over like 200, like 150, then it's 911, and we're not talking about
it's
it.
Time to get somebody. And I'm sure people are listening going, I'm sorry, you want me to go how long without saying, because we're all and you've been in the office, right? That's the thing. I'm already 4 minutes behind.
Yep.
This person not only needs a full mouth series, but their perio maintenance, and I got to do intraoral exams. And they didn't do their medical history and they had to pee before they came back.
Of course.
And now their damn blood pressure is through the roof. And now I got to wait another 5 to 10 minutes. I mean, I think we can all just say, obviously, their health is more important. We're just going to all have to come to terms with, we're not going to probably get it all done today.
And that's okay. Have them come back for that full mouth series, or you call that assistant to come and help you with that full mouth series at the end of the visit. If that's the case, I mean, you want to make sure that your patients are healthy and they have a good outcome. I don't need them to have like fancy teeth if they're not going to have a good outcome. They need to walk out of your office and be okay.
Absolutely. How do you guys feel about reviewing some terminology?
Sure.
So you said syncope earlier. I would just love, like, remind us all, because we also have some great professionals that have maybe gone on maternity leave, taken a little moment to raise some kids, and now they're coming back into it. And they're like, oh yeah, I remember stroke. I remember heart attack. I remember ischemic attack. I remember there was one that you said in one of I was like, wait, there's a difference. Where I have been out of the surgical side for a minute. So I was like, oh, I used to know all these words. Can we just have a lovely little review of terminology?
Absolutely. Absolutely. So syncope, it's kind of like a brief loss of consciousness caused by a reduce of blood flow to the brain. Okay. So essentially the person passes out. So what you can look for with that is they could be kind of sweaty. They could be anxious and want to hop up out of your chair super quick. The best thing for you to do for that person that's about to pass out, or they'll give you a blank stare. It's something that you're like, uh-oh. Just lay them back, put their feet up in the air and put their head down. That's called Trendelenburg position. It kind of forces the blood to flow to their brain so they can't pass out when you have them hanging upside down kind of thing in your chair.
High flow oxygen.
There's a lot of reasons why syncope, that fainting can happen. It can happen from a panic attack. It can happen from low blood sugar. It can be that vasovagal reaction, that fight or flight. They're so scared that you're going to poke number 5 at the gum line and they have that recession that they're sweating in your chair. It could be a heart problem. It could be related to heart medications kind of thing. It could be from alcoholism. They could be dehydrated. There's like reasons for this to happen. So when you see that odd look, if they start to sweat, start to get anxious, they feel kind of clammy, get them in your chair, get their head down, feet up, and put them on some oxygen. And it should resolve fairly quickly. If it doesn't, then what I would do is there's ammonia inhalants that most offices should have. And I can actually review some of basic things that offices should have. But the ammonia inhalant, as soon as you snap that, you put it underneath their nose, they're going to come back to you in seconds. If they don't, you get on the phone with 911 immediately.
So you wouldn't always call 911 if somebody passes out?
Absolutely not. Absolutely not.
Okay.
If it's not resolved within, 15, 20 seconds, now we're looking at possibly something else going on. And this is just the start of some other kind of medical emergency. So if it's syncope, then you should be able to resolve it fairly quickly.
All right. What else do we have? We have stroke. Let's say stroke, right?
Okay, stroke. So recognizing a stroke is not always the easiest thing, but a quick thing that you can do is think of FAST. F being facial drooping. The A is asymmetry or aphasia. The S is, do they have slurred speech? And the T is, if you see those things, it is time to call 911.
Okay. All right. And then what do you do for someone with a stroke? Just call 911?
Call 911. You put them in a semi-reclined position, monitor their vital signs, make sure that you have a medical history, a current medical history that you can go ahead and give the first responders when they come. You definitely want to stay with the patient, but there's really not much that you can do as a dental provider with a stroke other than to call 911 and just make sure that they're safe and monitor them until the EMS gets there.
All right. And what else do we have?
What about allergic reaction?
Ooh.
That's a common one for the dental office.
I have had that too in my chair.
You do stuff long enough, you see a little bit of everything. So an allergic reaction, that's a reaction from the immune system to an allergen or an antigen. And it can present with a skin reaction of hives or redness. You can even get blanching of the skin where it looks white. You can have respiratory problems with an allergic reaction as well. But when we start to talk about anaphylaxis, that is a life-threatening reaction. You're going to have nausea, vomiting, hives. They can have cramping. They can have tightness in their chest, coughing and wheezing. They can have pallor of their skin where they almost look gray, and it's not a good thing. They can be lightheaded. They can have tachycardia, which is a super fast heart rate. They can have loss of consciousness. We don't want to see any of that stuff in our office. So just a couple of things to be aware of is the patient's current allergies that they have. But here's some things that are in the dental office that as a dental provider, we may not think about. Latex. Latex is kind of not really even a thing now in the dental office, but local anesthetics, it can be rare to have that reaction to it, but you can have a reaction to it. And that can present with somebody that passes out. They have an irregular heartbeat. You can have, in the dental office as well, egg protein is an allergy to people. And I actually just found this out within the past year that nitrous oxide, it doesn't have egg protein contained in it. However, it can cause a reaction similar because there's a molecular similarity to nitrous oxide and egg protein. I know, right?
What?
Yeah.
And so I would imagine that reaction is different, or is that just like an increased heart rate?
Increased heart rate, they're going to have hives, they're going to probably be extremely anxious, kind of thing. You have patients that are allergic to milk protein, nuts, and gluten, and those are actually found in some polishing pastes and fluorides, and actually in some toothpaste as well. So that person with like celiac disease, they're gluten sensitive. So you want to make sure that your dental products don't have those things in there for those sensitive people. Kind of thing. When you do have that allergic reaction, if it's a skin reaction, Benadryl is usually the first line of that you would go to kind of help that. Go ahead and give them a Benadryl. That'll be in your first aid kit. If they start manifesting some respiratory distress, now we're talking about the EpiPen. Okay.
Okay.
EpiPen is something else that every office should have. That would be an intramuscular kind of auto injector that you could give the patient, or the patient could actually give it to themselves when you're talking about a compromised airway.
Yeah, I don't know how many, I'm not really super excited. Where do you stick the EpiPen? I always have this very Pulp Fiction like scenario that happens and like stabbing people in the heart, or like Horrible Bosses when he's like stabbing Kevin Spacey in the chest. I know that's probably not going to be the case, but I would assume the thigh.
You would do the thigh. You would do the side of the thigh between the hip bone and the knee bone, and you just
not in the heart.
Nope, not going to do it right in the heart. You could actually do it in their arm as well, but I think that the person would more appreciate that gigantic needle going in their leg than their arm.
Oh, is it giant?
It is huge. It is.
Oh, wow.
It's big, but it's to deliver the medicine as quickly as possible so that it doesn't escalate into an anaphylactic, life-threatening kind of problem.
Got it. Okay. Yeah, I've actually not had to do that before. Thank God. I was unaware of the length of an EpiPen needle.
They are probably half the size of a pencil. They are huge.
Oh, geez.
It's big. It's big.
Yeah, I would probably appreciate the thigh. Is the glute an option as well, or no?
No, it's got to be in the muscle. I mean, you could if you were super, super fit, but
which most Americans are not. Most Americans do not fall in.
That's right.
So let's talk about cardiovascular episodes.
Are we talking about some chest pain like angina pectoris, where there's like some discomfort?
Well, what are the more popular, no, I say popular, more common, as if people want to have this particular cardiovascular event. What's the more common one these days?
I would say angina pectoris is probably one of the first things that you would see. It is not necessarily life-threatening. It's chest pain or discomfort, and that is due to coronary heart disease that the patient already has. They may not be aware of it, but it's present. And this is a symptom that happens because the heart arteries are narrowed or blocked. So it's like an insufficient flow of blood to the heart. And that can happen with exercise, emotion, a heavy meal. It could be a decrease in oxygen, if the patient is hyperventilating.
And then what am I doing with them?
What you're going to do with them, you're going to make them comfortable. You're going to place some nitroglycerin underneath their tongue. Some offices have the little tablets, and some of them have sprays that you can spray sublingual. And you want to do that because there's more blood supply under there. It's going to be absorbed by the body quicker. One thing that I do want to say about nitroglycerin, if it is administered in the tablet, it's a small little bottle, and the bottle is tinted. Once you open that bottle, once it's exposed to air or light, you have like about a week or two before you have to throw it out. Right. Like once it's exposed,
so all the tablets in there. Okay.
Yes. So it is a consideration, when you're building your first aid kit, you may want to, do that sublingual spray because you can just spray it underneath their tongue and it doesn't affect the validity of like the tablet or the bottle of tablets that you may open, for that one incident, because hopefully you're not going to have multiple incidents, with that. But make them comfortable, give them some of that sublingual nitroglycerin, give them some oxygen and monitor them with some vital signs. If there's no improvement after 3 doses of that nitroglycerin, now you're going to go ahead and call 911 because they're probably having a heart attack. Okay.
And at that point in time, you will administer aspirin at 325 milligrams. The other contraindication of the nitro is that your patient is going to have a really bad headache. Their first complaint is that their head is killing them. And, that is one of the, again, contraindications of the nitro is that they will have that effect on them. But like Patty said, at that point, we're going to transport and we're going to do 911 to ER.
Is the aspirin going to help with that headache at all?
No,
Nope.
The aspirin is more for a blood thinning effect than it is for the negative effect of the nitro. So perhaps it might, but we're administering the aspirin for blood thinning effects.
Yeah. So how long does that headache usually last?
Every patient's different, Michelle, but I mean, generally it's as our body processes medications, it could be an hour to 6 hours in general.
Oh, wow. Yeah. And so if they are somebody who starts to feel better after just one spray of nitroglycerin, so I'm not exactly calling 911, but should I still be maybe calling an emergency contact? Or, do I want to let this person get in a car and drive?
No.
In the office?
Absolutely not.
Okay. No, you would want to have somebody come and pick them up, and it is definitely recommended that they go and see their physician.
Yeah, that once you administer, there are a lot of patients that take nitroglycerin fairly regularly as far as their regimen for prescription. Those folks are probably going to be a little bit more stable and familiar with that dose. But somebody that's a first time patient that we gave nitro to, they're going to go off to the ER to get further evaluated.
Okay.
So I did also want to share the recommendations by the ADA and the Council of Scientific Affairs. They do recommend 7 core drugs that belong in every office, in every kit, whether you are doing sedation, oral sedation, just local anesthetic. They do recommend having just these basic things. So the first one, of course, is oxygen. The second one would be glucose. Every kit should have some kind of glucose in it. You can buy it in a form that comes in a tube that you can also do sublingually. But if you don't have that available, even if you give them just a regular Coca-Cola or some cake icing can also help. For an allergic reaction, I would have that diphenhydramine, which is just the generic name for Benadryl. I would have that for in my kit. I would have the nitroglycerin for that chest pain, the angina pectoris. I would have albuterol in there, which is for your asthma attack or your bronchospasm. Definitely in the office. Have that 325 milligrams of aspirin in the office. And you also want to have epinephrine or an EpiPen in your office as well. In my kits, I always like to have an ammonia inhalant in there as well. I like to have a little steroid in case their allergic reaction starts to really get crazy. You can give them dexamethasone, which a lot of offices do have. And I would also have a simple paper bag for that person that wants to hyperventilate on you.
Oh, yeah. Yeah. Good old paper bag.
Some of the equipment that you should also have along with those drugs, you should have that portable little e-tank that rolls around on wheels. Have that available in case somebody's having a problem, in your lobby or something like that, where they're not in an op and you don't have that nitrous hood available to give them that oxygen. Have that ready. You also want to have, a bag valve mask, that ambu bag, in case you can't get that oxygen to them quick enough. You can start doing some rescue breathing for them. You definitely want to have a Yankauer suction. If y'all don't know what a Yankauer suction is, it's that tonsil suctioner it's plastic and it's really long and it has a little ball on the end. So if you do need to kind of go back into the back of their throat, you're not going to scratch them with that metal suction that we have in oral surgery that we use.
Right. And would that be for if somebody swallowed something?
You could do it if somebody swallowed something, if there's excess secretions, if they are having a laryngospasm or a bronchospasm, you can kind of evacuate everything that's, in there out, try to secure a patent airway. That definitely helps with that. You also want to have a backup suction that's not powered, that emergency manual or battery operated suction for that, emergency if the power goes out. Have an AED, y'all. Everybody have an AED. And the thing with the AED, make sure you check the expiration of the pads and make sure you check that battery at least annually to make sure that it's going to power up when you need it. And have a blood pressure cuff and a manual, stethoscope and blood pressure cuff so that you can check them manually. Sometimes these machines aren't all that accurate. If you do get some off the wall reading, I like to check my patients manually. Like, was that real or were they coughing while it was taking their blood pressure? You can get a false reading. So a manual one is always good to have as well.
All good suggestions. Are any other, points to make about cardiovascular events?
A heart attack.
Yeah.
You go for a full-blown heart attack. It's just a decrease in the oxygen to the heart muscle due to a complete or a full blockage. So the person's going to have chest pain. Unlike the angina pectoris, which is just the chest pain, this is going to last for at least 20 minutes or more. We're talking heart attack. Now they're going to the hospital. So what you would do is you'd put their feet up and make them comfortable, give them some oxygen. Like Bruce said, go ahead and give them that 325 milligram of aspirin, monitor their vital signs, and prepare for CPR.
Okay, so let's say I know we're supposed to be doing CPR on the floor. Am I going to be too prepared if I'm like, during a heart attack, can you just go ahead and lay on the floor?
They're probably
Is that probably something rude I should not say to
No, not at all.
they may not be all that willing to get up. But what I would suggest is, because they do recommend to do it on a hard surface, and I know that in some of the hygiene ops, your rooms can be a little bit narrow, so getting a person on the floor may not be an option. So what I would suggest, if you do have that smaller op, go hit the Lowe's or the Home Depot, get a nice piece of plywood, even like particle board, something. Keep it behind your door where you keep your warm-up jacket, slip it under them, and then that'll provide a harder surface. It'll make your compressions more effective to do it on a hard surface. So for those smaller rooms, I do recommend you don't have to get a fancy board that's meant for CPR, just as long as it's hard. Get a piece of wood and put it underneath them.
Yeah, that's a great idea.
The American Heart Association just changed the recommendations for 2020. And one of the things they did say is if somebody is in bed and they're having a heart attack, is to not pull them on the floor, but just do those compressions while they're in the bed. There's been many times where a patient is on a stretcher. We don't have the opportunity to get a board behind them or get them on the floor, obviously. So we are doing compressions on the stretcher in an ambulance while we're transporting. So every situation might dictate a little differently, but like Patty said, time is what's critical, and it's time that needs to happen quickly. Time needs to happen. Even with, we talk about bystander CPR, and you did take a class, and we talk about the relevance of a quick response. And that's really what our key is to have somebody initiate quickly. If it's in a bed, if it's on a stretcher, is to get those compressions started and get those compressions non-interrupted. And with COVID regulations now, and I'm happy to talk about that, is that we are deviating a little bit where maybe the pocket mask is not the safest thing for our person who is presenting the emergency care, is to maybe not do the breast, but go ahead and just do straight hands-on CPR. So there are things that is adapting with the new environment that we now call our COVID environment, but it's something that we certainly try to tell our students, if you don't have a mask, don't do it. Patty tells every student, if you use that mask, come into class and tell me what you did and how you used it and what happened, and I'll give you another mask, because we want to perpetuate the life-saving skills that we teach, but also we want to hear how they did that skill and how they performed that.
Yeah. And I would imagine, so I'm 5'2", 120 pounds. If I have a 200-pound male that's kind of dead weight, and I don't mean that like he's dead, but, he's probably not going to be able to move himself. Me trying to slip a board under him is going to take a minute, and I should be instead doing compressions.
Well said.
As much as I can.
Doing something quickly, first off, recognizing, call for help, and then doing something quickly. You have 4 minutes before the brain starts to die. So if you start something within those first couple of minutes, you increase the chance of survival 2 to 3 times. It's pretty significant of what we can do as far as CPR, as long as we recognize and we implement what we know without having to think about it. So practice.
So true.
You never learn an emergency.
Yeah. And honestly, what I do appreciate about your course and what I like about the new mannequins, I guess, the little dolls, the little CPR dolls, is the fact that it does give you that real-time feedback, so that you actually know how hard you have to press, you know how much work it takes, but also that you do get that moment to practice. Because I'm sure it's all going to be almost surreal, and it might take you a minute to like kickstart your brain, like should I be doing? But I would even say, why not practice as a team every quarter? Just like keep that thing fresh in your head. Because like you said, if it increases it by 2 to 3 times, that's huge.
And that's what they say with the practice is, even with the American Heart Association, they're moving more towards not doing this mass every 2 years. You just take this long course and you know it, because statistics prove that after you took my course, Michelle, within 3 to 6 months, you've forgotten what I've told you.
Not you, Miss.
Not you personally, but
no. I think sometimes, that you're correct. It is.
And so what they're trying to move more towards is shorter sessions and doing it quarterly. It's like minimal exposure, but more often, and people can keep up their skill. So it's kind of interesting how the science is going.
Well, you feel more confident, like right after your course, I'm like, yeah, I got this. Like, I think I could, but 1 year and 9 months later after your course, I'm like, it's 30. And am I doing breaths anymore? I think it's 2, but I can't remember. And babies are 50. Like, I can't remember. Now, is it 2-person or is it 1 per? I think it's so much better to have.
We always say that something means a lot more than doing nothing. If it's just compressions, we try not to focus on the numbers, but just the effect of doing a compression.
And the other thing that Bruce and I offer after our class to everybody that's ever taken our class is, if you ever do have that moment or you feel like your skills, you just don't remember, or something scary happens, we always offer, call me, come in. We can mess with the mannequins, because it's a lot easier to practice the skill and get kind of on top of it when it's not an emergency than when it is an emergency. So I always offer free of charge, like, come back in. Let's go with the mannequins for a half hour or something so that you feel like you got it back, and then carry on. I'm happy to do that because I believe in the skill. It's important.
No, that's fantastic. And just so the listeners know, this does not count as your CPR certification. You still need to go do it.
No, ma'am.
Well said.
Because this is, I will agree, like the mannequins and like being able to practice on those are, I think 2 years ago when I took your course the first time was the first time that I've ever had that feedback from the mannequin. I was like, damn, I don't think I've been doing it the correct way on these things before. Because I feel like I'm working up a sweat over here.
Yeah, for sure.
It's so true. And that's the good thing about the American Heart Association. They actually require us to have those feedback devices. And not only is it good for us as instructors to kind of guide you, but you can almost self-guide yourself when you see what you're doing, rather than me just standing above you saying, yeah, Michelle, you got it. And you're like, I got what? Wait.
Yeah.
Kind of thing. You can see for yourself and kind of know where you stand. So that's kind of a positive thing.
For sure. So, all right, we have somebody having a heart attack. We're calling 911. We're going to start doing compressions. We have angina, cardiovascular event, and anything else that falls in that category.
Okay. Cardiac arrest, just so that everybody's clear on this, a cardiac arrest and a heart attack are two separate things. A lot of people use them interchangeably. And I mean, even doctors use them interchangeably, but really simply, just to keep it easy for everybody, a heart attack is a plumbing problem. So there's a clog, basically a narrowing of the artery, and blood can't get through as quickly. So the heart attack or the cardiac arrest is an electrical problem where the heart is kind of firing off these electrical impulses, and it leads to an irregular rhythm. So the reason why we want to know the difference between these two things is when I talk about bringing in the automated external defibrillator, the AED, it'll do an analysis of the heart rhythm. If it detects an abnormal rhythm, it'll shock that abnormal rhythm, hoping to restore a normal rhythm. If it's not a shockable rhythm, then they could be having a heart attack, which is a myocardial infarction, and MI is the term that you would use.
And what is an AED or compressions going to do for that person if it's plugged? It's a clog.
Well, if they're having a heart attack, that clog problem, that can actually lead to the cardiac arrest. As like a first responder or somebody that's in the dental office, you're not going to be able to diagnose which one it is. But if it says that it's not a shockable rhythm, you're going to go ahead and continue doing that CPR and pumping their heart manually for them until EMS gets to you, for sure.
Okay. All right. Well, thank you for that understanding, or at least breaking it down for us, making it a little easier. I like it. All right. What are some other things that we could experience as a medical emergency in our practice?
Seizure is another possibility that you can have. And that is abnormal electrical activity that's happening in the brain. And there's a couple of reasons why that can happen. You know, if you look at their medical history and you see that they're epileptic, then we know that they have that. It's like a convulsion disorder. They can have that happen. Now, some seizures can go unnoticed. The person can have a blank stare. It can be very short. Most seizures don't last more than 5 minutes. If they do start to convulse, it's just a more intense kind of seizure. And in that case, the way that we would manage them is just kind of clear the area, get your Mayo stand out of their way, you know, or that bracket table out of their way, anything that they can possibly hurt themselves on. We don't want to restrain them. You certainly do not want to put anything in their mouth. We're going to call 911 for sure. And just make sure that their airway is clear, because with a lot of seizures, the patient can bite their tongue, and it's okay. It kind of stinks, but if you put something in their mouth, now you're compromising their airway. We could have like an obstruction. So that's why we don't want to do that. But when EMS, Bruce can tell you that when he comes in and does an evaluation on a patient and it's a possible seizure, the first thing that he's going to say is open your mouth. And if he sees, you know, that they have bitten their tongue or something like that, now he's going to think seizure and then start asking you as the provider some questions. Hey, did you see what happened? When did it happen? Did they hit their head? Kind of thing. So that now he can know, like, are we dealing with possible head injury or things like that kind of idea. If you happen to work in a surgical office, diazepam or Valium, you go ahead and give it to them, and that can calm the seizure down. But not all offices have that available. You can also use Versed too.
And are we calling the EMS pretty much Even with
Absolutely.
the blank stare, is it still called petite?
Yes.
Seizure?
Yep.
Yeah.
And yes, I would absolutely. It's kind of funny because when I was looking at some of this stuff, they said that seizure is a very common medical emergency that happen in dental offices. I've seen quite a few of them in the 27 years that I've been doing this. I've seen a seizure twice.
Oh, wow.
Yeah. So, and allergic reaction, syncope, those are going to be and chest pain are probably going to be your most common, though, I think.
Anything else on your list?
Low blood sugar. That's another one. If they're a known diabetic, we want to definitely ask them the last time that they ate, even if they're coming to see you for routine hygiene or something like that, like, hey, Patty, when was the last time that you had something to eat? And if I tell you yesterday, you may say, here's a little orange juice or here's a little soda before we go ahead and get started. And the way that they'll present is they'll be sweaty. They could be anxious. Their hands will be clammy and wet kind of thing. I've had hypoglycemia as a young child, and you do have, as the patient, you do have that kind of anxiety feeling of like, it's almost like a panic attack kind of feeling that a patient will present with. So you place them in a supine position, give them something sweet to eat, and monitor them for about 10 minutes or so, and it should subside. And then you can go ahead and carry on. That's not a 911 call unless it's not resolved within 15 minutes. Then you need to call.
And is this I know a lot of offices that are carrying glucometers. Yeah.
Yes.
Why I couldn't get that word out, but glucometers. Yeah.
Uh-huh.
Okay.
So what we're talking about, hypoglycemia, is below 50 milligrams per deciliter.
So whatever registers on that glucometer, like 50 and under, would be.
Give them something to eat. Yeah, give them some juice, give them some sugar, give them something, and then carry on. You can carry on as long as they're feeling up to it.
And what's going to be a little high, and what should we do about that?
Anything that's typically over
120.
I would say 140 for fasting.
True.
For fasting, if they come in and they're 140. And they haven't had anything to eat that day, that's pretty high. From a dental perspective, we would rather have them a little high, especially if we're talking about routine stuff. Surgery, you don't want them high, but you don't want them low. Low is more of an emergency with a diabetic patient than a high reading, okay? So if you get that high reading, they're going to have delayed healing with a surgical procedure, an extraction or something like that, but it wouldn't affect a hygiene thing. But what you would want to do is, if you have that glucometer and you get that high 140 of a fast, then you would say, hey, Mrs. Smith, I think you need to go ahead and see your physician again and get your A1C checked. What the A1C test is, it's going to kind of give you a number. You want to have like around a 6. What that number is indicating is what your blood sugar has been over the past 3 months on average. So at a 6, that's a blood glucose of 130, which is, for a normal person, that's okay.
All right. Good stuff. What else do we have on that list?
Well, like we were talking about before, Michelle, is one thing as far as history taking is if you do have a diabetic patient or somebody that's in your chair, you're going to ask one of the most important questions I ask is, when's the last time you ate? If I do a BGL reading and they are low, perhaps we're going to say, hey, maybe have a little juice, sugar water, something that's going to elevate that insulin level. Or what we're going to do is ask the person, well, if you're 140 or 200, I've had patients at 560, how are you regulating your blood sugar? Are you doing insulin? There's a lot of different insulins out there that you want to maybe get involved with how they're treating themselves and perhaps recommend getting a little bit better managed, because a lot of diabetics, I find, sad to say, is that they don't manage it the way that they should be, or they're just complacent with their protocol and not being on top of their personal treatment. And a lot of these folks I'll see are amputees and diabetics, and the end result is just not maintaining the values they really should be. So it's something that transcends through history, but also obviously patient care for themselves.
That's a great reminder. And I mean, we know that there's such a huge link between oral health and diabetes. And it's definitely a fine line of like, oh, I want to treat your mouth, but also like you can't come in here and, not be able to be controlled. It's something that I know a lot of offices are battling with, especially in certain patient populations where we just have a lot of unhealthy people in our country, unfortunately.
And
That's true.
they don't realize how important these things are. And they don't put together that, hey, my blood glucose is high, but oh, that's why my teeth are falling out kind of thing.
Yeah.
You know, they just don't put it, they don't think that one has to do with the other. And it is for overall health and being dental professionals, you know, we can see things manifest orally before the patient even has a symptom of it.
Absolutely. I think a lot of us have those stories of, you know, patients diagnosed with leukemia after we were like, something's just not right. What is going on here? Or diabetes, or I mean, so many things, right? We can go on for days of how the mouth is a window into the overall health in a lot of ways. Well, I just want to thank you guys so much for this update. You did a lovely job teaching us and reminding us. And I think the points that I took home are, you know, go through your first aid kit, make sure nothing is expired, make sure you have those 7 particular medications and the additions that you suggested. And for the love of all heart attacks, like get an AED. Like y'all just have an AED in your office and practice. Man, I can't even tell you. Like, I do feel like a champion after CPR. Like, I got this. I dare you to have a heart attack in my chair right now. I'd be so good at it. But then, you know, a year and a half later, I'm like, oh, has there even been any changes? Is it still a thing? So I think we should do it a little bit more frequently. And if you're in the Charleston area, you should check out Holy City Savers. Yeah?
Holy City Heart Savers.
Thank you.
Thank you, Michelle.
Holy City Heart Saver.
Hey, Michelle, one last thing we always press with our students is when you go to work or you go to your office, ask the question, where is the AED? Where is the fire extinguisher? Know where those things are at. So if you need them, you can get to them and you can get to them very quickly. We're very complacent with, we have it, but where is it? On an ambulance, we know where every item is and where it's placed and how many of those items are placed. So let's not forget the fact that we need to get to those items quickly and know exactly where they're at. So it's an important thing to remember.
And something else that I actually would like to share, it's something that I saw today, actually on Facebook, and I was kind of surprised that a dental assistant had asked a question about a protocol, and another dental assistant, her response was, well, you're working under the doctor's direction and it's his call and you're not going to get in trouble and kind of whatever it. And I was like, whoa.
About it. Yes.
But like, no, you know, if you think about, you know, my particular situation, it was my boss that I had to help. You know, you don't want to have to rely on somebody else. Like, you want to have this on your shoulders, because I can tell you that 70% of cardiac arrests that happen outside of a hospital are in a residence. It's not even at work where you have to do it. But we're talking about somebody's home where, you know, it's your aunt, your uncle, your grandma, your grandpa, your parent, that you don't want to have to think about this stuff, you know, and doing CPR on my boss was a lot different than doing it on a stranger, because my emotions were tied into it. Not that I did anything different other than afterwards I wanted a big drink because it was very emotional.
Probably a few of those, some of those hefty pours. But I would also say, like, you just don't know who is going to freeze in an emergency situation.
Correct.
That is very true.
Yeah, well said.
And I think that if you are the doctor, you're not omnipotent. You're not going to be able to know that person is always going to be able to perform. And like you said, what if it is on that person that is supposed to be the lead in the office for emergency situations? And I mean, I've actually seen, in my particular situation where we had 2 doctors in the practice, the one who was performing the surgery and we ended up having to trach his patient, it wasn't him that did the emergency stuff. It was the other doctor. Because I don't even know I have no memory of where that man was in the room. Like, we were all there hustling, and I don't know, he could have been having a dang coffee for all I know, but I know it was not him. So you just don't know who's going to take responsibility and who's going to kind of freeze up. So we should all take responsibility of learning.
Well said.
Absolutely.
Awesome. Well, thank you guys so very much for your time. If anybody has any questions or wants to know any more, can they reach out to you?
Absolutely. I can be reached by phone call, by text. I can be emailed.
What's your email? Tell us all and we'll put it in our show notes.
Okay. We are holycityheartsavers@gmail.com.
Perfect. And is that the website as well?
That is the website as well. And I can be reached by my cell phone, 843-906-4060. The only time that I don't answer is typically on Sundays. And if I'm teaching a class. Other than that, I'm all ears and I will answer any questions you have.
Well, Patty and Bruce, thank you so much for your time today. We really did learn a lot from you, and I think we'll all feel a little bit better if we are ever in that unfortunate situation of a medical emergency.
All right. Well, I hope you're not.
Andrew, how often do you think we should get our CPR renewal? Do you think 2 years is fair?
Look, I think that's the bare minimum. But you said it in the intro, and I was thinking about it. I'm like, you know what? You're right. I think every year, if there's a way to do it, like, so here's my thoughts on that. Like, I feel like there needs to be that refresher, but like maybe like an in-depth and a refresher, in-depth, like maybe alternating years, because the problem is honestly scheduling 4 hours or 6 hours or however long your state mandates for this course. I mean, that's really cumbersome on people in addition to all the other things we have to do.
But it doesn't need to be that long. See, I think if you do bite-sized chunks spread out, like you're going to retain the information. It's going to be refreshed more frequently. You don't have to do those giant chunks of time. Like you said, it's like 4 to 6 hours and practicing. I honestly think it should be a quarterly thing. And so half every 6 months it flip-flops. So like once it's didactic, like here's your renewal. Here's what you do with seizures. Here's what you do with the heart attacks. Here's what you do with strokes. And then the next time it's like, okay, we're going to reenact a medical emergency in your office. Wouldn't that be great? Like, here is your AED. Here is how you would get a patient out of your chair. Or here's how we would solve an issue if you couldn't get them out of the chair, or whatever it looks like. I just think that makes so much sense.
And I think, for some of the bigger clinics, it's nice to have the appointed people for certain tasks, for certain days that they're working. I mean, because I know medical emergency, like, okay, you go call 911, you go wait by the thing in for the ambulance and put them this way. Like all of those jobs, those roles. It's nice to have those defined and then role play those. And so I like that quarterly thing, but that's obviously at the office level. But sometimes when you have so many people, it's actually worse than your 3 or 4 person staff that's in an office sometimes.
Yeah, because either you have way too many cooks in the kitchen or not enough cooks in the kitchen. Exactly. And I brought this up in the interview, but I think it's super important. She brings up that, the assistant was like, do I really need to do this? Because ultimately it's my doctor that would do it. And you're like, yeah, but she brought up her point that she was doing it on her doctor during a surgery. Like he had the medical emergency. And then also, I'll be very frank, like we're all trained, but you don't know who's going to show up in an emergency. People act very different in the heat of the moment. And some people you're like, oh, they're so quiet, but they kick into gear. And some people are frozen. And that's why everyone needs to know. And I think honestly, it's just practice. Like, where's the AED? Do we test it? Where's the mask? Do we have a bagger? Where's the oxygen? Like, where's our first aid kit? Are we going through it? Do we know what we use in the event of this? But we get real lax. We're so lax sometimes.
That's true.
But anywho.
Nice to have this refresher podcast though.
Yeah. So thank you to Patty and Bruce. And I think that's it. Well, if you want to reach out to us, you are welcome. And also reach out to Patty and Bruce. They gave email. Patty gave her phone number. I mean, these people are really in it to make you successful. But you can reach out to us at ataleoftwohygienist.com, on Facebook, on Instagram as ataleoftwohygienist.com, also LinkedIn. And if you want to reach out to either one of us individually, we are Michelle at ataleoftwohygienist.com and Andrew at ataleoftwohygienist.com. And thank you to PDT for always sponsoring the CE portion of this podcast, because you will get CE credit. Just click the links in the link in our show notes, where you'll take a test and you will get your self-study CE through CE Zoom. And PDT, make sure that you can get that. And they have done that since day one, and we thank you so very much for that. Anything else?
I got nothing. Have a great week, everybody.
All right. Bye, y'all.